Welcome to Pediatric Case Review. Today's lecture provides a comprehensive clinical review of panhypopituitarism. We will explore clinical presentation, examination findings, pathophysiology, diagnostic approaches, treatment strategies, and potential complications. This presentation uses case-based multiple-choice questions to enhance your clinical reasoning skills. Let's begin our journey through this complex endocrine disorder. Case scenario: a 35-year-old woman presents with fatigue, weight loss, and amenorrhea for 6 months. Question: what defines panhypopituitarism? Option A: deficiency of growth hormone only. Option B: deficiency of anterior pituitary hormones only. Option C: deficiency of all anterior pituitary hormones. Option D: deficiency of posterior pituitary hormones only. The correct answer is C. Panhypopituitarism refers to the deficiency of all anterior pituitary hormones, including growth hormone, thyroid-stimulating hormone, adrenocorticotropic hormone, luteinizing hormone, follicle-stimulating hormone, and prolactin. This condition may also involve the posterior pituitary, leading to diabetes insipidus. Understanding this comprehensive hormonal deficiency is crucial for proper diagnosis and management. Case scenario: a 42-year-old man developed severe headaches and vision changes. Brain imaging revealed a large pituitary mass. Question: what is the most common cause of panhypopituitarism in adults? Option A: Sheehan syndrome. Option B: pituitary adenoma. Option C: traumatic brain injury. Option D: congenital hypoplasia. The correct answer is B. Pituitary adenomas are the most common cause of panhypopituitarism in adults, causing compression and mass effect on normal pituitary tissue. Other important causes include Sheehan syndrome, pituitary surgery, radiation therapy, traumatic brain injury, and infiltrative diseases. The mechanism involves mass effect, ischemic damage, or direct surgical trauma to the gland. Case scenario: a 2-year-old boy presents with severe growth failure and recurrent hypoglycemia. Brain imaging shows a small pituitary gland. Question: what is a common congenital cause of panhypopituitarism in children? Option A: pituitary adenoma. Option B: septo-optic dysplasia. Option C: postpartum hemorrhage. Option D: craniopharyngioma in infancy. The correct answer is B. Septo-optic dysplasia is a common congenital cause of panhypopituitarism in children, characterized by midline brain defects. Associated features include optic nerve hypoplasia and absent septum pellucidum. Other congenital causes include genetic mutations affecting pituitary development, pituitary hypoplasia, and craniopharyngioma. Early recognition is essential for preventing complications. Case scenario: a 6-year-old girl has height below the 3rd percentile. Growth velocity is 2 centimeters per year. Question: what is the most characteristic presentation of growth hormone deficiency? Option A: tall stature with delayed puberty. Option B: short stature with slow growth velocity. Option C: normal height with early puberty. Option D: macrocephaly with normal growth. The correct answer is B. Growth hormone deficiency characteristically presents with short stature below the 3rd to 5th percentile and markedly slow growth velocity, typically less than 4 centimeters per year. Additional features include delayed bone age, increased central fat mass, and doll-like facies with frontal bossing. Recognizing these growth patterns is critical for early diagnosis. Case scenario: a 28-year-old woman complains of cold intolerance, weight gain, and constipation for 4 months. Question: which symptom cluster suggests thyroid-stimulating hormone deficiency? Option A: heat intolerance, weight loss, diarrhea. Option B: cold intolerance, weight gain, constipation. Option C: polyuria, polydipsia, weight loss. Option D: tremor, palpitations, anxiety. The correct answer is B. Secondary hypothyroidism from thyroid-stimulating hormone deficiency presents with cold intolerance, weight gain, and constipation. Other symptoms include profound fatigue, dry skin, hair loss, and bradycardia. Unlike primary hypothyroidism, laboratory findings show normal or low thyroid-stimulating hormone levels with low thyroxine, reflecting pituitary rather than thyroid gland dysfunction. Case scenario: a 50-year-old man presents with profound fatigue, nausea, and weight loss. Blood pressure is 90/60 millimeters of mercury. Question: what distinguishes secondary from primary adrenal insufficiency? Option A: hyperpigmentation present. Option B: hyperkalemia present. Option C: no hyperpigmentation or hyperkalemia. Option D: severe dehydration always present. The correct answer is C. Secondary adrenal insufficiency lacks hyperpigmentation because adrenocorticotropic hormone levels are low, not elevated. Hyperkalemia is also absent because aldosterone production from the zona glomerulosa remains intact. Patients present with fatigue, hypotension, hypoglycemia, and hyponatremia. Understanding these differences is crucial for accurate diagnosis and appropriate management. Case scenario: a 32-year-old woman reports absent menstrual periods for 8 months, decreased libido, and vaginal dryness. Question: what characterizes luteinizing hormone and follicle-stimulating hormone deficiency in women? Option A: heavy menstrual bleeding. Option B: amenorrhea and low estrogen symptoms. Option C: hirsutism and acne. Option D: galactorrhea alone. The correct answer is B. Luteinizing hormone and follicle-stimulating hormone deficiency in women causes amenorrhea and estrogen deficiency symptoms, including hot flashes, vaginal dryness, and decreased libido. Long-term consequences include accelerated bone loss leading to osteoporosis and infertility. Hormone replacement therapy is essential to prevent these complications and improve quality of life. Case scenario: a 40-year-old man complains of decreased libido, erectile dysfunction, and reduced muscle mass over 2 years. Question: what are key features of gonadotropin deficiency in men? Option A: gynecomastia and testicular enlargement. Option B: low libido, erectile dysfunction, decreased muscle mass. Option C: excessive facial hair growth. Option D: deep voice and increased aggression. The correct answer is B. Gonadotropin deficiency in men presents with decreased libido, erectile dysfunction, reduced muscle mass, increased body fat, and decreased bone density. Laboratory findings show low testosterone levels with inappropriately low or normal luteinizing hormone and follicle-stimulating hormone levels. Testosterone replacement therapy significantly improves symptoms and prevents long-term complications. Case scenario: a patient reports bumping into objects on both sides. Visual field testing shows peripheral vision loss in temporal fields bilaterally. Question: what visual field defect suggests pituitary mass effect? Option A: unilateral blindness. Option B: bitemporal hemianopia. Option C: central scotoma. Option D: homonymous hemianopia. The correct answer is B. Bitemporal hemianopia, characterized by loss of temporal visual fields in both eyes, results from pituitary mass compression of the optic chiasm from below. The decussating nasal retinal fibers are most vulnerable to compression. This finding indicates suprasellar extension of the mass and requires urgent neurosurgical evaluation and intervention. Case scenario: during examination, a patient appears pale with fine facial wrinkles and sparse body hair. Question: what examination findings suggest chronic panhypopituitarism? Option A: coarse facial features and thick skin. Option B: fine wrinkles, pallor, sparse body hair. Option C: flushed face and excessive sweating. Option D: acanthosis nigricans and skin tags. The correct answer is B. Chronic panhypopituitarism produces characteristic physical findings including pallor, fine facial wrinkles, and sparse body hair due to multiple hormone deficiencies. Additional examination findings include thin skin, decreased axillary and pubic hair, low blood pressure, bradycardia, and decreased muscle mass. These findings reflect the combined effects of growth hormone, thyroid, and sex hormone deficiencies. Case scenario: a 4-year-old child has height and weight below the 3rd percentile, cherubic face, and high-pitched voice. Question: what examination findings are typical in childhood panhypopituitarism? Option A: tall stature with advanced bone age. Option B: short stature with immature appearance. Option C: normal growth with precocious puberty. Option D: obesity with stretch marks. The correct answer is B. Childhood panhypopituitarism presents with severe short stature and immature appearance. Examination reveals cherubic facies, high-pitched voice, micropenis in boys, increased truncal fat, and delayed tooth eruption. Recognition of these features enables early diagnosis and treatment initiation, which is crucial for optimizing growth potential and preventing life-threatening adrenal crises. Case scenario: a patient with panhypopituitarism has blood pressure of 85/55 millimeters of mercury and heart rate of 52 beats per minute. Question: what cardiovascular findings are expected? Option A: hypertension and tachycardia. Option B: hypotension and bradycardia. Option C: normal blood pressure with irregular rhythm. Option D: wide pulse pressure and bounding pulses. The correct answer is B. Panhypopituitarism typically causes hypotension from cortisol and thyroid hormone deficiency, and bradycardia primarily from hypothyroidism. Patients exhibit reduced cardiac output and decreased exercise tolerance. These cardiovascular changes can be life-threatening during stress or illness. Appropriate hormone replacement therapy gradually normalizes cardiovascular function and improves patient outcomes. Case scenario: skin examination reveals pale, smooth, thin skin with minimal wrinkles and decreased sebaceous gland activity. Question: what skin findings differentiate secondary from primary adrenal insufficiency? Option A: hyperpigmentation and skin creases. Option B: absence of hyperpigmentation. Option C: bronze discoloration. Option D: darkening of scars and mucous membranes. The correct answer is B. Unlike primary adrenal insufficiency, panhypopituitarism causes pallor without hyperpigmentation because adrenocorticotropic hormone levels are low. The skin appears thin, smooth, and finely wrinkled. This absence of hyperpigmentation occurs because melanocyte-stimulating hormone, which shares precursors with adrenocorticotropic hormone, is not elevated. Recognizing this difference helps distinguish between pituitary and adrenal causes. Case scenario: a patient reports headaches. An examination reveals reduced visual acuity and papilledema. Question: what neurological findings suggest pituitary apoplexy? Option A: peripheral neuropathy. Option B: sudden severe headache with cranial nerve palsies. Option C: gradual onset tremor. Option D: chronic daily headaches only. The correct answer is B. Pituitary apoplexy presents with sudden severe headache, visual field defects, and cranial nerve palsies, particularly affecting cranial nerves 3, 4, and 6, causing ophthalmoplegia. This medical emergency results from hemorrhage or infarction of a pituitary tumor and requires immediate glucocorticoid administration and urgent neurosurgical consultation to prevent permanent neurological damage. Case scenario: laboratory shows low thyroid-stimulating hormone, low thyroxine, low cortisol, and low testosterone. Question: what is the primary pathophysiology in panhypopituitarism? Option A: peripheral hormone resistance. Option B: hypothalamic pituitary axis failure. Option C: target organ destruction. Option D: autoimmune hormone antibodies. The correct answer is B. The primary pathophysiology involves hypothalamic pituitary axis failure, where the pituitary gland cannot produce adequate tropic hormones. This creates a cascade effect with low pituitary hormones leading to deficient peripheral hormone production. Causes include tumor compression, surgical damage, radiation therapy, ischemic injury, and infiltrative diseases affecting the pituitary gland. Case scenario: a patient with a slowly growing pituitary adenoma first lost growth hormone, then gonadotropins, then others. Question: what is the typical sequence of hormone loss? Option A: adrenocorticotropic hormone first, then others. Option B: growth hormone first, then luteinizing hormone and follicle-stimulating hormone, then thyroid-stimulating hormone, then adrenocorticotropic hormone. Option C: thyroid-stimulating hormone first, then others. Option D: all hormones lost simultaneously. The correct answer is B. The typical sequence of hormone loss follows: growth hormone first, then luteinizing hormone and follicle-stimulating hormone, followed by thyroid-stimulating hormone, and finally adrenocorticotropic hormone. This pattern reflects the anatomical distribution of hormone-producing cells, with lateral pituitary cells affected before central cells. Although adrenocorticotropic hormone deficiency occurs last, it poses the greatest immediate danger. Case scenario: a patient presents with symptoms suggesting panhypopituitarism. You need to order initial hormone testing. Question: what hormones should be measured initially? Option A: only thyroid-stimulating hormone and thyroxine. Option B: only cortisol and adrenocorticotropic hormone. Option C: free thyroxine, cortisol, testosterone, or estradiol, insulin-like growth factor 1, prolactin. Option D: only prolactin and growth hormone. The correct answer is C. Initial testing should include free thyroxine, morning cortisol, collected between 8 and 9 in the morning, sex hormones, testosterone in men, estradiol in women, insulin-like growth factor 1, and prolactin. Additional tests include thyroid-stimulating hormone, gonadotropins, electrolytes, and glucose. This comprehensive panel assesses all pituitary axis simultaneously and guides further dynamic testing. Case scenario: morning cortisol is 4 micrograms per deciliter, low. Adrenocorticotropic hormone is inappropriately low normal. Question: what test confirms adrenocorticotropic hormone deficiency? Option A: dexamethasone suppression test. Option B: concentropin stimulation test. Option C: insulin tolerance test or corticotropin-releasing hormone test. Option D: 24-hour urinary free cortisol. The correct answer is C. The insulin tolerance test is the gold standard for confirming adrenocorticotropic hormone deficiency, producing hypoglycemia to stimulate cortisol release. The corticotropin-releasing hormone test is an alternative. Both assess pituitary adrenocorticotropic hormone reserve. Absent or blunted cortisol response confirms central adrenal insufficiency. The insulin tolerance test is contraindicated in seizure disorders and cardiac disease. Case scenario: a child has short stature and low insulin-like growth factor 1. Random growth hormone is undetectable. Question: why is random growth hormone measurement unreliable? Option A: growth hormone is stable throughout the day. Option B: growth hormone has pulsatile secretion. Option C: growth hormone is always elevated. Option D: growth hormone does not exist in blood. The correct answer is B: growth hormone has pulsatile secretion with peaks occurring during sleep, making random measurements unreliable. Insulin-like growth factor 1 serves as a screening test, reflecting integrated growth hormone secretion. Confirmatory testing requires growth hormone stimulation tests using arginine, glucagon, or clonidine. Peak growth hormone less than 10 nanograms per milliliter confirms deficiency. Case scenario: laboratory confirms panhypopituitarism. You need to identify the underlying cause. Question: what is the best initial imaging study? Option A: computed tomography scan of head without contrast. Option B: magnetic resonance imaging of pituitary with gadolinium. Option C: X-ray of skull. Option D: ultrasound of head. The correct answer is B: magnetic resonance imaging of the pituitary with gadolinium contrast is the best initial imaging study. It provides superior soft tissue resolution, clearly visualizes pituitary anatomy and pathology, and detects microadenomas as small as 3 millimeters. Common findings include adenomas, empty cellus syndrome, hemorrhage, infiltrative diseases, and pituitary hypoplasia. Case scenario: magnetic resonance imaging shows a 2 centimeter pituitary macroadenoma with suprasellar extension. Question: what additional testing is essential? Option A: electroencephalogram. Option B: formal visual field testing perimetry. Option C: audiology testing. Option D: electromyography. The correct answer is B: formal visual field testing using automated perimetry is essential for all patients with macroadenomas showing suprasellar extension. This testing detects chiasmal compression, establishes baseline visual function, and monitors treatment response. Bitemporal hemianopia indicates optic chiasm involvement requiring urgent surgical consideration. Ophthalmologic assessment should be performed before and after any intervention. Case scenario: a patient with confirmed adrenocorticotropic hormone deficiency needs glucocorticoid replacement. Question: what is the standard glucocorticoid replacement regimen? Option A: dexamethasone once daily. Option B: hydrocortisone 15 to 25 milligrams divided in 2 to 3 doses. Option C: prednisone 100 milligrams daily. Option D: no treatment needed. The correct answer is B: standard glucocorticoid replacement uses hydrocortisone 15 to 25 milligrams daily, divided into 2 to 3 doses. 2/3 is given in the morning and 1/3 in the afternoon, mimicking natural circadian rhythm. During illness or surgery, doses must be doubled or tripled. Monitoring focuses on clinical response while avoiding over-replacement complications. Case scenario: a patient needs thyroid hormone replacement. Current cortisol replacement is adequate. Question: what is the correct approach to initiating levothyroxine? Option A: start high-dose levothyroxine immediately. Option B: ensure adequate cortisol replacement before starting levothyroxine. Option C: start levothyroxine before cortisol. Option D: never give levothyroxine in panhypopituitarism. The correct answer is B: cortisol replacement must be adequate before initiating levothyroxine therapy. This critical rule prevents adrenal crisis, as levothyroxine increases cortisol metabolism. Standard dosing is levothyroxine 1.6 micrograms per kilogram daily. Monitor using free thyroxine levels, not thyroid-stimulating hormone, because thyroid-stimulating hormone remains inappropriately low in secondary hypothyroidism. Case scenario: a 35-year-old woman with panhypopituitarism has amenorrhea and low estrogen. Question: what is appropriate sex hormone replacement? Option A: no treatment needed. Option B: estrogen plus progesterone, if uterus intact. Option C: testosterone only. Option D: progesterone only. The correct answer is B: women with intact uterus require estrogen plus progesterone replacement to prevent endometrial hyperplasia. Estrogen alone is appropriate only after hysterectomy. Benefits include osteoporosis prevention, symptom improvement, and bone density maintenance. Contraindications include breast cancer history and active thromboembolic disease. Regular monitoring ensures safety and efficacy. Case scenario: a 40-year-old man with panhypopituitarism has low testosterone and sexual dysfunction. Question: what is the appropriate testosterone replacement? Option A: oral testosterone tablets. Option B: intramuscular, transdermal, or gel testosterone preparations. Option C: estrogen therapy. Option D: no treatment recommended.